cysts are a frustrating problem for people to experience. These are abnormal cells that are related to hair follicle cells, and this problem tends to cause pain and redness and swelling as well as drainage from the tailbone area. We call them sacrococcygeal cysts, pilonidal cyst disease with abscesses often. Most commonly, pilonidal disease afflicts people in their 20s, teens, their 30s, but occasionally we do see people who are older who also have this problem. It is increasingly thought that this is an acquired condition that develops during those years of life with some abnormal hairs, a type of ingrown hair, if you will. Other people think that this is still a congenital problem. Whatever the root cause of it, what we find with pathologic examination is that abnormal cells have formed deep beneath the skin, down deep in the subcutaneous layers, and in fact the cyst cavity has traveled all the way down to, or grown from, the periosteum, the layer sitting right on top of the bone, that lining or tendinous membrane on top of the bone of the tailbone. The treatment for this problem involves removing that tissue completely. The surgery is not a big surgery, but it is a potentially big recovery process afterward. The surgery involves a person being under anesthesia, turned and faced lying on their stomach in a prone position, and the area where the cyst has been present is removed completely. It's important, and we try very hard as surgeons, to widely remove it and not leave behind any vestiges of the abnormal cells, no tracks left behind so that it doesn't recur. Lessons learned from decades in the past were that trying to be very minimalist and removing very little tissue resulted in a high rate of recurrence of this problem and having to undergo the surgery a second time, which nobody wants. So, in the best hands, the surgeon removes the tissue widely and completely. That then leaves a wound, and the management of this wound has been a subject of debate for many years, in fact decades. Today, when the wound is fairly small, most of us in colorectal surgery, experts in treating wounds and in treating pilonidal disease, do try to close it. And what we do is close those tissues together as best we can. Sometimes we'll leave a drain of some sort, and we will try to foster conditions where it can heal. And healing typically has to occur to some degree from the bottom up. The trade-off between primary closure and another technique, which I'll describe in a moment, is that with primary closure there's a higher risk that it won't heal, that bacteria and fluid will remain trapped underneath the skin and will fester and form an abscess or an infection. That can require a second surgery to open and drain it or wash it out, and then move on to trying to have it heal from the bottom up by what we call secondary intention. In many other cases, if the wound is very large, we know that trying primary closure is unlikely to succeed, and so we embark upon another method. Historically, that method has been packing with gauze and changing the dressings every day, twice a day, or 3 times a day in some cases. This process can take a very long time. In fact, often, historically, it's been a 6-month process to heal such wounds, which have to slowly heal or granulate from the bottom up. There have been some advances in wound care that have allowed us to accelerate the time for healing quite substantially. In the large pilonidal cyst cavities, what I have employed in more recent years is the use of a novel regenerative growth matrix, a so-called extracellular matrix, or ECM. And studies have demonstrated that a product called Matristem, made by a company called Acell, specifically promotes healing of site-specific tissues, meaning that it will cause granulation of healthy tissue, including healthy muscle, healthy skin, healthy subcutaneous tissues. It does so by specifically recruiting some healing cells called macrophages of a particular subtype, the so-called M1 subtype of macrophages. Unlike the other products that have come along that are extracellular matrices, it does not result in a firm scarring sort of process, but rather a tissue-specific healing that is more like a regenerative process of your own tissues. What we've found with the use of Matristem is that pilonidal wounds heal much more rapidly. We've written a peer-reviewed paper about the experience with healing of difficult pilonidal wounds, and we've seen the time shrink dramatically from the 6-month time frame to as little as 6 weeks. It's also a process that is much less painful and much less cumbersome than other options available, such as wound packing or the use of a wound vac. Both of those are uncomfortable and cumbersome, carrying around extra dressings or, in one case, a wound vac system. With the use of Matrixstem material, the regenerative growth matrix material is placed in the wound and allowed to work, and then weekly a person comes to my office and I or one of my team members will change the dressing in the office, add more of the Matrixstem powder if necessary, or graft material if necessary, and then continue to work with the person on a week-to-week basis until it's fully healed. We think this process has dramatically accelerated the time for total healing, and it's also markedly increased the comfort of the person who's experiencing the problem, allowed them to return to work and return to school much sooner than they would have otherwise if we had chosen a different method. I think in the future we'll see more of these extracellular matrix materials come along. I've been very impressed and won over by Matrixstem because of its experience with the Iraq War veterans and wounded who are returning with very difficult blast injuries and traumatic injuries, and we've seen the effects on accelerating wound healing in that very difficult patient population. I have seen how successful Matrixstem can be in helping heal these sometimes very challenging pilonidal wounds, and we've seen that as a real improvement in our practice and in what we can offer to people who are suffering with this problem. Normally, the surgery itself just takes about a half an hour. It's an outpatient surgery. So if you're having this problem, you come in, have it done in an outpatient surgery center typically, go home the same day, and then you just leave the packing and leave the dressing alone, allow it to work its magic, really, to allow it to stimulate your own tissues to begin healing, and then see us on a weekly basis until we get it fully and completely healed. But with most pilonidal wounds, I usually tell people that there may be a chance somewhere during the course of the healing that we go back to surgery and wash it out and apply something to it in order to stimulate wound healing, or we attempt to bring the tissues together in some fashion, or just clean out areas that aren't healing. What we found so far with the use of the Matrixstem powder is that we have not had to go back to surgery and wash it out, although I'm sure that may be the case at some point. So far, however, it's just been a very nice linear progression from wound to fully healed, scarred process. And that's something that you can see with photographs on our website and in this paper that I described. Ultimately, the key for pilonidal disease is to see a qualified and very experienced person who works very hard to get it done right the first time, has a very low chance of having it recur, and then helps you get that wound healed in as fast and convenient a time frame as possible. That's what I think that we're offering and what we're trying to do, and continue to improve that process.